starting in the management of stroke, guided by leading experts in the field. So, we are using today's bulletin as an opportunity to come together and make the biggest possible noise about stroke and the need for action, keeping in mind the World Stroke Day, which is on 29th of October. So, the theme for 2024 is to be greater than stroke, which is focused firmly on the prevention of stroke. As we know, 90% of strokes are prevented by addressing a handful of risk factors, among which physical inactivity is the topmost. So, this year's campaign relies on harnessing the physical power of sport and physical activity to raise awareness and drive action on stroke prevention. Early recognition and prompt action is also essential, along with focused rehabilitation programs to support survivors. It is also crucial to prevent recurrence, as 1 in 4 survivors are at a risk for another episode of stroke. So, keeping in mind the theme for stroke, our journal club today will be addressing the long standing challenge of determining the optimal blood pressure following endovascular therapy for ischemic stroke, which remains a question of great debate even today. Our speakers are going to shed more light on whether lowering the blood pressure post endovascular therapy improves neurological outcome, or whether this will worsen cerebral perfusion in the face of aberrant cerebral autoregulation. I hereby welcome the moderator for today's session, Dr. Sharmishta Pathak, who is an assistant professor from All India Institute of Medical Sciences, New Delhi. And the speaker today will be Dr. Shivpriya, who is working as a senior resident also from AIIMS, New Delhi. So, warm welcome and over to you both.
Thank you, Dr. Ashwini. So, as we dive into today's study, we will examine how precise personalized blood pressure management post recanalization could be the key to improving patient outcomes, emphasizing the importance of personalized care in neurocritical care setting. Over to you, Shivpriya.
Good evening, everyone. Today we are going to deal with an article which is published in Journal of American Heart Association in April 2024. It titles "The Deviation from Personalized Blood Pressure Targets Correlates with Worse Outcome After Successful Recanalization." We all know that endovascular therapy has improved prognosis in the large vaso-occlusive stroke, but the optimal blood pressure targets after a successful endovascular thrombectomy have still not been defined in the literature. So, given the variability of the stroke factors and the comorbid factors of the patient's cerebral autoregulation evaluation and optimizing the blood pressure targets to a cerebral autoregulation would be an acceptable and reasonable option. The previous studies which have taken the cerebral autoregulation evaluation have found that the cumulative time that BP exceeded the CA limits were associated with unfavorable outcomes. Now the question is whether only the time or the degree with which the duration of BP deviation from CA limits also affects the outcomes. This has not been explored in the previous literature, and this is the key point of the study. This study aims to test if the burden of deviated BP within the first 48 hours after endovascular thrombectomy was associated with unfavorable outcomes. Going ahead with the methodology, this study is a single center prospective observational study conducted in the Beijing Tianjin Hospital and which included 18 to 85-year-old patients with large vaso-occlusive stroke who underwent endovascular thrombectomy and successful recanalization, and this was defined by modified treatment in cerebral infarction score of 2B to 3. These patients also had premorbid modified Rankin scale of 0 to 2. We have excluded the patients who had hemorrhagic transformation before the CA monitoring was started, who had isolated anterior cerebral artery or vertebrobasilar tertiary infarcts, who have comorbidities like aortic dissection, congestive heart failure, hepatic failure, subclavian artery stenosis, or who had poor acoustic window for TCD examinations. All the patients who have enrolled in the study have received the treatment according to the 2018 current AHA guidelines. The BP targets were set according to the 2018 guidelines only. And after the endovascular thrombectomy, the others proceeded for the TCT-based CA monitoring in these patients. This was conducted within 48 hours after EVT in each patient. And the bilateral MCA velocities were recorded through the temporal window at a depth of 50 to 65 mm, and this was recorded once or twice in the 48 hours. The parameter used was the mean flow velocity. It is monitored in a 300-second window period from the, it is interpreted at 0 or negative is considered as CA preserved, and approaching one is considered as a dysfunctional CA. Here in the study, a threshold of plus or equal to zero point 0.4 is taken for the mean flow velocity. And whenever the mean flow velocity was recorded, synchronously arterial mean arterial pressure was also recorded for 2 to 4.5 hours continuously for each patient. After recording this, the map was divided into groups of 5 mmHg and it was plotted against the mean flow velocities which were recorded during that time. For example, the graph shown here is a mean flow velocity and the map recordings of a single patient which were recorded. In this, we can see when the threshold of 0.4 is, zero point 0.4 is taken, a U-shaped map curve is obtained which intersects this threshold of 0.4 at 2 points. At 92.5 mm of Hg of map and at 116 mm of Hg of map, which are the lower and the upper limits of cerebral autoregulation for this particular patient. Like this, for every patient, a graph was derived. The nadir of the curve is considered as map optimal, and vasoparalysis is a situation where the U-shaped curve is entirely exceeding the threshold of 0.4. After this, the routine care included upper arm cuff pressure recording at least every 2 hourly. And from this, the map was calculated from the systolic and diastolic blood pressure. And these upper arm cuff pressures map was plotted over the time for the patient. Like this graph is of the same patient which we have discussed in the earlier slide, where the map is pointed against the time. And here we can see 3 zones. The green zone is the zone where the map was within the autoregulatory limits. The red colored zone is a zone where the map was above the autoregulatory limits. And here they have described 2 parameters. One is the burden above the range, which is the area enclosed by the map curve above the upper limits of cerebral autoregulation. And time above range, which is the percentage of cumulative time for which map stayed above the upper limit. Similarly, the blue area is the area where the map was below the lower limits of autoregulation. And here 2 parameters have been described. Burden below the range, which is the area enclosed by the map curve below the lower limits, and time below the range, which is the percentage cumulative time with which map stayed below the lower limit. And for vasoparalysis, burden out of range was the area between map curve and map optimal. After obtaining such curves, the parameters measured for each patient were NIHSS score, which was measured at admission and at 7 days or at discharge from the ICU, whichever is the earliest, and modified Rankin scores at 90 plus or minus 7 days, infarct growth, which is the difference in the infarct volume at 7 days and the admission infarct volume. And the significant infarct growth is described as the volume of infarct growth more than 11.6 ml. Time above and below range of map, burden above and below range of map, and early neurological deterioration, which is increase in NIHSS at 7 days by at least two points. And hemorrhagic transformation in the study is stratified as no hemorrhagic transformation or hemorrhagic infarction and parenchymal hematoma. The hypothesis of the study was that the longer time out of range and larger burden out of range of MAP are associated with increased risk of early neurological deterioration, greater disability at 90 days, which is described by the MRS score of 3 to 6, a higher delta NIHSS value from admission to 7 days. And longer time above range and larger burden above range are associated with higher risk of intracranial hemorrhage within 48 hours. And longer time below range and larger burden below range are associated with higher risk of significant infarct growth at 7 days. The primary outcome was unfavorable functional independence level, that is MRS score of 3 to 6 at 90 days. And secondary outcomes were early neurological deterioration, delta NIHSS, and significant infarct growth at 7 days, ICH within 48 hours after recanalization, and MRS score at 90 days. The statistical analysis was performed using the Wilcoxon-Ransom test, chi-square test, t-test, Fisher-Exact test for comparing the two unadjusted samples. Kruskal-Wallis test was used for more than 2 independent samples. Spearman correlation coefficient was used to examine the correlation between 2 variables, and odds ratios of dichotomous variables and correlation coefficients for continuous variables were used in logistic and linear regression models. A p-value of less than 0.05 was considered statistically significant. Now, proceeding to the results, This study was conducted between May 2020 and February 2022, and a total of 200 patients were screened in the study, and 120 TCD based CA monitoring sessions were performed. In total, 91 enrolled patients, and all the patients successfully completed the follow up in the study. When we are analyzing the baseline parameters, the admission NIHSS median value was 13, and the admission mean map at admission was 107 with a standard deviation of 20 mmHg, and post procedural the mean map was 97 mmHg with a standard deviation of 10 mmHg. And the total percentage of time out of range was 75.9, burden out of range was 295 mmHgr, and 38.5% patients had hemorrhagic transformation, with 17.6% patients who had early neurological deterioration, and 90-day MRS of 3 to 6, that is poor outcome, was found in 61.5% patients. Now, on dealing with each of them individually, our primary outcome was the association of time and burden of BP with MRS at 90 days. So here we have two scatter plots in which we can see the first one is showing the association between the time out of range, percentage cumulative time out of range of MAP to 90-day MRS score, where we can see at the score of 3 to 6, 90-day MRS score of 3 to 6 had wider time out of range values with a higher medians. And the similar trend was observed in the burden out of range also, where the 3 to 6 MRS score had higher medians of burden out of range, where uh, on analyzing the p values, both the p values were significant initially. Both the time out of range and burden out of range were significantly associated with 90-day functional outcome. On multivariate analysis, it was found that only burden out of range had the significance maintained, and it was significantly associated with 90-day functional outcome, poor, which is MRS score of 3 to 6 with a p-value of 0.027. Proceeding further, our secondary outcomes, deviation of MAP association with delta NIHSS. Here the correlation curves which shows that both the time out of range and burden out of range was significantly correlated with the deviation of MAP above the range, out of range, in which the p-values were 0.10 and 0.16. On further analysis of logistic regression model, we can see that only the burden out of range was significantly associated with delta NIHSS, where the p-value was 0.043. Moving further to the infarct growth and early neurological deterioration, the 7-day infarct growth also followed the similar trend, where the burden out of range, the correlation was maintained in the burden below range, where the burden below range was significantly associated with 7-day infarct growth with a p-value of 0.039, whereas the time below the range was not associated with 7-day infarct growth. On further analysis, the early neurological deficit, initially both the early neurologic was as both time out of range and burden out of range were significantly associated with early neurological deficit. On further logistic regression mode application of logistic regression model, we can find that only the time out of range was significantly associated with early neurological deterioration, where the adjusted odds were 1.38, whereas significant infarct growth, only the burden below range was significantly associated with infarct growth volume of more than 11.6, which carried an adjusted odds of 1.21. On coming to the next outcome, deviation of BP association with the hemorrhagic transformation. Here we can see the in both time out of range and burden out of range was significantly associated with ICH. The patients who had ICH had higher time above range and higher burden of MAP above the range. On further regression analysis, it was found that only time above the range was associated with the map. Time out of range was associated with the symptomatic ICH, where the adjusted odds were 1.56 for every 10% increase in the time above range. The adjusted odds were 1.55 for ICH. In this study, around 31.9% of subjects had vasoparalysis. Patients with vasoparalysis had overall larger pre-procedural infarct size than those without, and this was statistically significant. On a subgroup analysis, after removing the patients who had vasoparalysis, still the primary outcome had been maintained. That is, increased burden out of range was still associated with the higher risk of poor outcome, MRS score of 3 to 6 at 90 days. To summarize our key findings in the results, delta NIHSS was associated with both time out of range and burden out of range, but linear regression showed it has a correlation between NIHSS and the burden out of range only. And burden below range was significantly associated with significant infarct growth, and only time above range was associated with intracranial hemorrhage, whereas 90-day poor outcome, burden out of range was associated with poor outcome at 90 day, that is MRS scores of 3 to 6. Proceeding further to discussion, over to you, ma'am.
Starting with the critical appraisal of the article, first of all, is the study question relevant? Definitely, this study dives into an intriguing discussion between intriguing correlation between blood pressure deviations and patient outcomes. It addresses a critical gap between personalized blood pressure targets and outcome of stroke patients. The research question is highly relevant in present neurocritical care settings, particularly in optimizing post-endovascular thrombectomy management. Although this study focuses primarily on blood pressure management, but it is a single center observational study, thus the generalizability of the subject is slightly limited. And it does add newer findings as it gives evidence that personalized blood pressure targets do help in managing the stroke patients better. Putting the study in the PICOT format and discussing the research question, the study has targeted a specific population between 18 to 85-year-old patients who have had stroke of especially the anterior circulation, and they have well-defined criteria of patients who have benefited from endovascular thrombectomy. They have applied transcranial Doppler-based cerebral autoregulation and calculated personalized blood pressure targets for each and every individual enrolled in the study, and they have completed it for 91 patients. The outcomes of the study show that personalized blood pressure management, not only the time is important, but the blood pressure map above and below the range of the personalized targets helps in identifying the functional status of the patient at the end of 90 days. The time frame of the study has been appropriately calculated, and they have used 90 days modified Rankin scale outcome to assess and find out how the patients have fared when their blood pressure has been tried to be kept between the specified targets calculated based on TCD based autoregulation. Now, there are various methods of assessing the cerebral autoregulation using that has been used in the present study. Other intracranial signals have been used previously, and there have been randomized controlled trials using near infrared spectroscopy, local brain tissue oxygenation, and you can also be using ICP monitoring from CSF draining system. Dwelling into a few of the studies, one is that published in Stroke in the year 2020, which compared fixed with autoregulation oriented blood pressure thresholds after mechanical thrombectomy for ischemic stroke. They employed 90 patients and used NIRS based autoregulation measurement and measured same modified Rankin scale outcome at 90 days. And they found that percentage time with mean arterial pressure above the upper limit of autoregulation was associated with 90-day outcomes. The key differences from the present study were that present study employs individualized blood pressure management, and they have used both time as well as burden of blood pressure, which has stayed out of cerebral autoregulation limits. And besides using NIRS was used in the stroke study, they have used TCD for evaluating the cerebral autoregulation and have used a threshold index of plus 0.4, which they have calculated based on previous other studies. Using TCD as the method of assessing cerebral autoregulation provides a more global coverage of the area as compared to NIRS. Looking at few of other studies, the BEST 2 trial and the Enchanted 2 study. In the BEST 2 randomized controlled trial, after the patient underwent endovascular therapy, they divided them into 3 groups, randomizing into one where the SBP was targeted between 40 to less than 140, secondly between 40 to less than 160, and the third group was the guideline recommended 40 to 180 group. And futility boundaries were assessed, that is 10 ml increase in the follow-up infarct volume or a zero point 0.1 decrease in the utility weighted MRS score. They found that lower systolic blood pressure targets less than either 140 or 160 did not meet the criteria for futility compared with the target of 180 millimeters mercury or less. In the Enchanted 2 study, 821 patients were randomized to maintain the target systolic BP less than 120 within 1 hour of recanalization, and the likelihood of early neurological deficit and poor functional outcome was found to be greater in the patients who were intensively managed for blood pressure. In another study, that is the BP target, which was a multi-center open label randomized control trial, 324 patients were assigned to intensive systolic blood pressure target group, where the blood pressure was maintained between 100 to 129. And they found that they could achieve this target within 1 hour after randomization, maintained it for 24 hours. And the rate of radiographic intraparenchymal hemorrhage at the end of 24 hours was found to be 43% in the intensive therapy group as opposed to 42% in the standard therapy group. So, having a single fixed target for blood pressure may not be appropriate for all patients due to difference in perfusion needs of every individual. Thus, to guide individualized blood pressure management in this study, not only the duration but also the extent or the burden of actual blood pressure that deviated from the autoregulation preserved blood pressure range was measured. Previous studies, patients with high, moderate to high, or high to moderate systolic blood pressure trajectories were more likely to have unfavorable outcome. And in this study, burden was calculated, which provided a possible explanation for poor outcomes. So every 100 R millimeter mercury increase in the magnitude that BP deviated from the cerebral autoregulation limits had a 1.28 fold increase in the odds of a poor functional outcome at 90 days. Looking at a study which has been recently published in Journal of Neuroimaging, where they have stated that transcranial Doppler ultrasound used for evaluating the risk of hyperperfusion after endovascular stroke thrombectomy had a higher chances of prediction. So they predicted hemorrhagic transformation in 20 participants, which was about 48% of the total study participants. Now, was the study design appropriate? Study has been appropriately designed, although it is an observational study and requires further randomized control trial before we can bring it into our clinical practice. This study addresses the potential source of bias, as they have tried to perform blinding of the radiologists who have performed the scans to detect the increase in the infarct volume. But they were not able to completely control the bias, as the addresser who is performing the TCD was not blinded in the study. This has been performed in line with the original protocol which they laid out, and they have been able to perform the statistical analysis justifiably and correctly and appropriately. It has been applied by calculating linear regression analysis. Although when the question comes about generalizability of data, that would be slightly difficult to ascertain it to a larger population because of the observational nature of the study. Thus, larger randomized trial which compare and use TCD for individualized cerebral autoregulation limit determination would be more helpful in determining the generalizability of the data of the present study. So in the present study, deviation of BP was found that the time the blood pressure is out of cerebral autoregulation range was associated with early neurological deterioration, and the burden out of cerebral autoregulation range also followed a similar trend, but although it was not statistically significant. The burden below cerebral autoregulation limit, that is the amount of blood pressure which fell below the limits of autoregulation, was definitely associated with significant increase in infarct volume. This suggests that blood pressure reduction has contributed more towards worsening of perfusion, has reduced microemboli, clearance, and thus has led to infarct progression. So the symptomatic intracranial hypertension found in this present study was found to be associated with blood pressure, especially above the upper limit of cerebral autoregulation. The limitations of the present study are that it is a single-centered, observational, moderate sample size study, has a low frequency. There is spot measurement of blood pressure and cerebral autoregulation. So time and burden out of range may be relatively inaccurate. And thirdly, the baseline NIHS score is taken at admission, and they have not calculated it after successful endovascular thrombectomy has been performed or just at the time of enrollment. Thus, we cannot reflect actual improvement from successful endovascular thrombectomy. Looking at few of the timeline of BP targets over the time which have come regarding management of acute ischemic stroke. Firstly, AHA came with their guidelines in the year 1994, where they said that if the BP is more than, unless the BP is more than 220 systolic or mean arterial pressure more than 130, we should withhold our antihypertensive. It took them almost 10 years to come with the next guideline, where they said that unless the diastolic BP is also more than 120 or SBP of 220, antihypertensives should not be given. They also added a point about thrombolytic therapy, that it should not be given if the systolic BP is more than 185 or diastolic BP is more than 110. In the year 2007, AHA again came with the guidelines where they included the role of RTPA therapy, and they said that thrombolytic therapy should be used, you should use after you have lowered the systolic BP to less than 185 and diastolic to less than 110. And after a successful therapy, you should keep the diastolic less than 120 and diastolic less than 105 and systolic less than 180 for at least 24 hours after the therapy. In 2013, they did not add anything new to this. In 2018, they also added mechanical thrombectomy by keeping the targets of blood pressure same. In 2021, ESO came out with the guidelines in which they said undergoing IV thrombolysis less than 185 by 110 before bolus, and we should keep it less than 185 by 105 before infusion. They also suggested against lowering systolic blood pressure to target of 130 to 140 compared to less than 180 during first 72 hours after symptom onset. 2018 AHA guidelines recommend BP measurement and treatment strategies. They recommend that we should measure blood pressure after every 15 minutes during and after IV alteplase infusion has been started for 2 hours. Then we should be measuring it every 30 minutes for next 6 hours and every 1 hour 24 hours following the alteplase infusion. And we should increase the frequency of blood pressure measurement if at any point the systolic blood pressure is more than 180 or recorded diastolic blood pressure is more than 105 millimeters of mercury. Looking at few trials which focus on blood pressure targets and effect on outcome. The SCAS trial, which came in 2011, where candesartan was used till 7 days, did not show any sign of benefit. Then came the ENOS trial in 2015, where they used transdermal NTG within 48 hours, again without showing any benefit in functional outcome at 90 days. The MR-ASAP trial in 2022 again used transdermal NTG for 24 hours, but they started within 3 hours of symptom onset, and they found that there was no significant benefit. In the INVEST trial in the year 2000, which came for ischemic stroke, they used nimodipine low dose or high dose and found that diastolic blood pressure reduction of more than 20% in the high dose group had worse outcomes at 21 days. The CATIS trial in 2014 used enalapril followed by CCB and third line diuretic to reduce the systolic blood pressure by 10 to 25%, and patients with modified Rankin score of more than 3 at 14 days did not differ, and 3 months did not differ between intervention and control group. The ACCESS trial in 2003 also found that BP target reduction of 10 to 15% using candesartan had significant difference between mortality and vascular events in the two groups. So lastly, coming to the conclusion, the present study shows that after successful recanalization, the percentage of time and burden of blood pressure outside the autoregulation preserved range correlates with both short-term and long-term clinical outcomes. Progression of infarction is associated with the magnitude of blood pressure below the lower cerebral autoregulation limit, whereas the relationship between significant symptomatic intracranial hypertension, hemorrhage, and blood pressure above the upper limit is time dependent. It is suggested that not only the percentage of time, but also the burden of blood pressure out of cerebral autoregulation preserved range should be minimized.
All right, so I think a very good critical appraisal and a very thorough literature review. So thank you to you both. Ma'am, I had one question. So I could not help but notice a key difference in this study, as compared to previous work in the field, is in how they assessed the cerebral autoregulation. A study that you discussed earlier on, a study by Peterson et al., they used near infrared spectroscopy, I think. So where do you
Yeah.
think that stands against, TCD based evaluation of cerebral
So
autoregulation?
yeah, so basically NIRS based autoregulation is more regional, where we have applied the probes, while TCD based autoregulation covers a larger area, as it covers the area completely supplied by the MCA. So that is where TCD becomes a more global application as opposed to NIRS, which is a little more regional application. So it gives a better outcome for cerebral autoregulation limits.
Okay. And what about the spot assessments? How practically feasible do you think in the Indian scenario is continuous autoregulation guided, management of blood pressure? Can we assess it continuously? Like,
Yeah, so in our Indian scenario, it may be difficult at present, but if we start doing even intermittent measurements and help defining the cerebral autoregulation of our limits of our patient, probably with the availability of ICM Plus software in future, we may be able to apply it continuously for our patients and help in getting them better outcomes after stroke therapy.
right, right. So I think all in all, the speakers have convinced me. And I think, having a single fixed blood pressure target may not be appropriate for all patients, due to the differences in their history of hypertension, which may be reactive in some, and the adequacy of collateral circulation, which is going to ultimately determine their cerebral perfusion. However, I think in addition to, stratified ranges of blood pressure, we also need to keep in mind factors like variability and the trajectory. So they also need to be evaluated. But in the end, I think it all comes down to personalized BP management, which requires continuous assessment of cerebral autoregulation. So we need, accurate, but at the same time, practical and economical monitors of cerebral autoregulation. They are the need of the hour right now. Yeah. So if you have any questions, please feel free to post them. Our faculty will address them later on. Right, so there are no comments on this. Yeah, all right. So let's wrap it up. Please do not forget to subscribe to our NCSI education channel. We have lots of events coming up, keeping in mind the theme of this month, that is stroke. We have a PBLD and we have a panel discussion on stroke as well. So we hope to see you all again in the next session. So
Thank
I
you so
thank the
much, Dr.
speakers for taking their effort and time and giving us a very good journal club today. So thank you so much, ma'am and Dr. Shri.
Rashmi. Thank you so much. Thank you.